All right, so we're going to go ahead with the presentation on radionuclide assessment of cardiac dyssynchrony, methodology and applications. So I'm going to first talk about dyssynchrony in general. It is somewhat technical, and dyssynchrony didn't start off with radionuclide imaging, at least from a clinical standpoint. And then now it has picked up with radionuclide imaging. I'm going to show how we can do it, what extra information we get, and how we can apply it or start applying it on a clinical basis. Okay, these are my disclosures. So dyssynchrony, left ventricular dyssynchrony. So when I talk about dyssynchrony in my refer to dyssynchrony, it's going to be all left ventricular dyssynchrony. I'm going to talk about why. So dyssynchrony is a medical condition wherein the contraction of the different walls of the heart is improperly synchronized. And these are two examples of patients who have remodeled and dilated ventricles. Typically, the posterior and the lateral and the septum should come in, should oppose each other. But in these two cases, the walls are actually moving away from each other. So it is ineffective contraction. Okay, and for the heart to provide effective contraction, the walls have to oppose each other. In this case, the walls are moving away from each other, which is referred to as dyssynchrony. Now, dyssynchrony can occur at various levels. It can be AV dyssynchrony, which is between the atria and the ventricles, which is example is a complete heart block. A ventricular dyssynchrony, which can be interventricular, so between or intraventricular. Interventricular would be between the two ventricles, the right and the left ventricle. And intraventricular would be just within the left ventricle or just within one ventricle, in this case the left ventricle. It can be electrical or mechanical. Electrical is what we refer to as a left bundle branch block or a white QRS ECG. Those signify electrical dyssynchrony. And mechanical dyssynchrony is the example I just showed when the walls don't contract in sync. Now, the reason we are focusing on left ventricular dyssynchrony alone is from this ERNA study that was done in 2002 that showed when comparing interventricular, that is between the right and the left ventricle, or intraventricular, it was the intraventricular dyssynchrony that was more closely related to cardiac function as assessed by cardiac index and ejection fraction. So the ejection fraction is right here, cardiac index is on the top. This is interventricular delay, this is intra or left ventricular delay, and as you can see, a greater left ventricular delay was associated with poor function, whereas an interventricular delay was really not associated or related to cardiac function and ejection fraction. So this knowledge of desynchronous ventricular contraction is why something called a biventricular pacemaker was developed to provide cardiac resynchronization therapy. And a biventricular pacemaker consists of three leads. One lead goes into the atrium, one lead of the pacemaker goes into the right ventricle, and the third lead goes from the coronary sinus towards the lateral wall of the left ventricle to provide simultaneous activation of the right and the left ventricles to improve contractility. And data for the efficacy of CRT comes from many randomized controlled trials. This is one such trial, the companion trial, that shows that patients who have a biventricular pacemaker, patients with heart failure, symptomatic heart failure who are on medical therapy for heart failure, those who receive a biventricular pacemaker or CRT device have better outcomes as opposed to those who don't receive a biventricular pacemaker and are continued on a medical therapy alone. Now, dyssynchrony can be performed with various imaging modalities, and actually it can be done with CT as well. Primarily has been done with echocardiography. Most of our literature on dyssynchrony comes from echo. Initially it started off with M mode or motion mode echocardiography, which has the highest temporal resolution of any imaging technique, and now it's done with speckle tracking echocardiography. As we're going to talk about, it is nuclear cardiology or radionuclide imaging is an established technique to assess dyssynchrony. Cardiac MRI and cardiac CT are emerging. Central to all the modalities for assessing dyssynchrony is assessment of myocardial thickening. All the modalities focus in some way to figure out when the myocardium thickens. and compare the timing of myocardial thickening with different segments of the left ventricle to determine if there is dysynchrony or delay in contraction between the walls of the left ventricle. So this table essentially shows you the comparison between different modalities for assessing dysynchrony. It goes from reproducibility, temporal spatial resolution. Reproducibility is excellent for SPECT. For echocardiography, it's not that good. Temporal resolution and spatial resolution is much poorer for SPECT as compared to other modalities. And importantly, radionuclide imaging gives us information on scar burden, volumes, left ventricular volumes, left ventricular scar burden at the same time, which echocardiography does not. CT can to some extent, MR can for sure, but again, the application of CT and MRI in terms of assessing dysynchrony are fairly limited. So, left ventricular dysynchrony predicts response to biventricular pacemaker and outcomes. This was an echo-based study that showed that if you had dysynchrony, which here is identified by having higher values of time to contraction or taking more time to contract, then the improvement or reduction or change in the left ventricular volume was greater, okay, but if you didn't have dysynchrony. So, if you had dysynchrony to begin with, you received a biventricular pacemaker, there was a greater improvement in your LV function, there was a greater reduction in left ventricular systolic volumes. Left bundle branch block and QRS width, which are considered as electrical determinants of dysynchrony, were not predictive of response to CRT in these patients. Similarly, in patients who had dysynchrony, which was again, this is an echo-based study, dysynchrony predicted symptomatic response and reverse remodeling with a specificity of about 80 to 90% for predicting improvement. And dysynchrony was the only predictor of response to CRT, ejection fraction, electrical dysynchrony from left bundle branch block, QRS duration was not a predictor of improvement in LV function. Even more importantly, if you did not have dysynchrony to begin with and you received a biventricular pacemaker for resynchronization, you had worse outcomes. So, these are the patients on the bottom who had dysynchrony defined by time to contraction of greater than 65 milliseconds, that is the peak contraction of greater than 65 milliseconds, whereas those patients who did not have dysynchrony, in whom the delay in contraction between the two walls was less than 65 milliseconds, patients who had dysynchrony had better outcomes with CRT, whereas those patients who did not have dysynchrony prior to receiving a biventricular pacemaker. Okay. So, dysynchrony is prevalent in patients who have heart failure. It can be imaged, at least with echo, so far we have seen, and also with other modalities. It predicts response to CRT and survival. A left bundle branch block, which is considered a typical feature of dysynchrony, or which characterizes dysynchrony, does not equate to mechanical dysynchrony. So, even though you have electrical abnormality, that may not translate into mechanical abnormalities, and CRT in the absence of mechanical dysynchrony could be harmful. So, what is the role of guiding dysynchrony in guiding clinical management? This is a flow chart from the ACC AHA guidelines as to in whom to implant a biventricular pacemaker for CRT. Okay. So, the first thing is you have to be a patient with symptomatic heart failure, ejection fraction less than equal to 35% on maximum medical therapy. Okay. So, if you have a left bundle branch block, you get a class 1 indication. If you have a wide QRS more than 150 milliseconds, you are a class 2 indication for CRT. So, electrical dysynchrony features in evaluating patients' appropriateness for CRT implantation, but mechanical dysynchrony really doesn't, even though prior observational studies have shown that mechanical dysynchrony is an important predictor of response to CRT and improvement in function, and implanting biventricular pacemakers in patients who don't have mechanical dysynchrony can be harmful. Okay, so if we just look at the way the guidelines work, this is the current state of the art. Patient selection is based on patient symptoms, LV function, wide QRS, and randomized controlled trials have suggested that at least 2/3 of the patients respond in some way, that is either improvement in symptoms or improvement in LV function, which isn't too bad. But the real deal is if you look at the data from the Miracle trial, which was a trial of patients with CRT in patients who had heart failure, only about 50% of the patients improved their symptoms by 1 NYHA class, and profound improvement by 2 NYHA class only happened in 16% of the patients. So even though the improvement was better when compared to controls, only about half the patients derived some benefit. Okay, depending upon how you define your benefit, if you define it by NYHA class of about more than 1, then 50% of the patients felt improved. However, only 38% felt that they had marked improvements in their symptoms subjectively. Okay, so one could say 1/3 to 50% of the patients don't improve after CRT, even based on the selection based on the current guidelines. So there is a need to guide CRT. As you can see, patients who have NYHA class 3 and over 4 heart failure, there is a mortality reduction of 36%, heart failure hospitalization reduction by 39%. This was in patients who have mild heart failure. And what about patients who have non-left bundle branch block abnormality, right? We know that patients who have left bundle branch block derive the greatest benefit, and I'm going to talk about that in the subsequent slides. But what about patients who don't have a left bundle branch block? They are desynchronous as well. So yes, so there is a need to guide resynchronization therapy because it's expensive. Okay, it's more expensive than putting an ICD. It is invasive, and we know from clinical trials that even though it is better than not providing CRT, no more than 50% of the patients improve with this expensive therapy. Right? Cost is estimated to be about $100,000 per life years gained. And we need to prospectively identify patients who qualify, whose quality of life would be improved by CRT. The use of this therapy would be far more economically attractive. Okay, so routine implantation of CRT is not cost effective, but a properly targeted use could be. So why does our mechanical dysynchrony assessment does not feature in our guidelines? Okay, so as I said, most of the data on dysynchrony evaluation has come from echo, and echo has poor reproducibility. This is data from the SPECT trial, which was published a year before I started fellowship, and there was a lot of excitement about dysynchrony and CRT, and it was a wash. The reproducibility of the echo indices, all listed here that you don't have to memorize, was really, really bad, and the combined accuracy to predict a CRT response was poor, 0.6. Okay. The echo CRT study was more contemporary, recently done in 2013, and the patients were those who had a narrow QRS but were reported to have dysynchrony on echo, and they were randomized to whether they should receive a CRT device versus not receiving a CRT device. And as you can see, those who received dysynchrony guided CRT did worse. So the outcomes, mortality outcomes or the cardiovascular outcomes was worse in patients who had dysynchrony guided CRT implantation versus guideline guided CRT implantation. So there's a disconnect between observational data and randomized controlled trials with respect to dysynchrony. Observational data suggests that dysynchrony is important. Randomized trial, at least in patients who have a narrow QRS, does not. And the PROSPECT trial just showed that dysynchrony indices by echo was just so bad, so poorly reproducible that they could not be applied on a clinical basis. So the first question is, why is dysynchrony failing to predict CRT response? Okay, so some studies have shown it does, but clinical randomized trials show it doesn't. Is there a technical limitation? And on the left is a diagram of the muscle orientation, the myocardial orientation of the heart. And as you can see, there are 3 ways the muscles are oriented. There are longitudinal fibers, there are circumferential fibers, and there are rotational fibers. Okay? The way we assess dysynchrony on echo is 2-dimensional. Either longitudinal assessment with longitudinal strain or speckle tracking, or a circumferential assessment. Now this is tougher and less reproducible than longitudinal strain assessment is. So all you are assessing is the change in the fiber length in one direction, whereas you know that myocardium contracts not only longitudinally, radially, but also rotationally. So we are missing so much contractility in the myocardium, which if we only assess that in a 2-dimension and instead of a 3-dimensional assessment. So gated SPECT for assessment of dysynchrony seems to overcome this problem. An assessment of dysynchrony on SPECT, which can be extrapolated to PET as well, is based on the partial volume effect. Okay, so SPECT inherently is a poor spatial and a temporal resolution technique, but the advantage of that poor spatial resolution is that there is a linear relationship between thickening and count density. So as your myocardium thickens in systole, there is an increase in the count density of the myocardium, as you can appreciate here. In systole, your myocardium is brighter and it has more counts as opposed to in diastole. Okay, so keep that thought in mind. So to this poor spatial resolution, we apply something called as the Fourier transformation. Okay, if anybody of you have biomedical backgrounds, Fourier transformation essentially converts the time data into frequency data. Okay, so we are trying to figure out the frequency and the timing of contraction of the myocardium. Okay, and this technique is called the phase analysis. So we are analyzing the phases. Phase means time. Okay, phase is another way of saying time. So we want to know the timing of myocardial contraction. In phase analysis, the myocardium is divided into numerous voxels, about 600 voxels. So the whole heart, the whole perfusion data set is divided into 600 volumetric points. Okay, and thickening of these 600 volumetric points is separately assessed. Okay, the myocardium is the thinnest in diastole, thickest in end systole or peak systole. Okay, and application of a Fourier transformation changes the thickening curve into a count-based curve. Okay, so you're assessing the change in the counts over the 8 or 16 frames of the cardiac cycle. Okay, now one must know when the myocardium starts contracting, and for the purposes of phase analysis, we identify that point as the phase in the cardiac cycle when the mean count density of a voxel, when the count density of a voxel goes over the mean count density. For let's just say in this voxel, the maximum count density is about 200, the mean is about 100, and at phase 46 degrees, which is within the first frame of cardiac cycle, the count density increases over the mean count density for that voxel during the entire cardiac cycle, and that point is referred to as onset of mechanical contraction. So this OMC, or onset of contraction, is the time point where this one voxel is set to start to contract. Okay, so this myocardial voxel contracts at phase or time 46 degrees. So that's another thing that the Fourier transformation does. It changes a time into time is referred in degrees instead of milliseconds. Okay, so your frames is one way of timing, millisecond is one way of timing your cardiac cycle, and degrees is the expansion of the milliseconds or the frames into a more resolute way of determining timing of contraction, because now you have 0 to 360 degrees for your voxels to contract, and you can compare the timing of those voxels with more fidelity than if it was only based on 8 or 16 gates. So let's say your myocardium is made up of lots of voxels, as I said, 600 voxels. The phase analysis converts, has two components, a frequency component on the y-axis and the time component on the x-axis, and the time, again, as I said, is in degrees. Okay, so this voxel contracts at, let's just say, this time point in the cardiac cycle, and then you have numerous other voxels, and this phase analysis is performed for all these 600 voxels in the cardiac cycle to define when, not only when they contract, but also how many of them contract at that particular time. So that is the frequency. The frequency represents the number of voxels contracting at that phase in the cardiac cycle, and the x-axis is the phase of the cardiac cycle. Okay, so this is done for over 600 myocardial voxels, and we develop from that a phase polar map, a phase histogram, which is a histogram representation of all the myocardial voxels contracting over the cardiac cycle. You can also represent that as a polar map that allows you to assess the sequence of mechanical activation as to where does the activation start, where does the activation end, and if you segment your polar maps by 17 segments, you can identify the sites that are the earliest sites to contract and the latest sites to contract, and that has clinical value, and I'm going to show that later. Any questions so far?
Do you regularly do 8 frames or 16?
We do 8 frames, but you can do 16 as well.
You switched to 16 years ago.
Yeah, so 16 is fine. We used to do 8 frames or 16 frames, but you need at least 8 frames, which is normal clinical practice, and phase analysis is applicable to 8 frame gating. So what are the components of a phase analysis? So you have a phase histogram on the top, okay, which is a nice narrow phase histogram, and on the polar map you can see the sequence of mechanical activation that gives you a qualitative assessment of how the myocardium contracts. In addition to that, you have quantitative measures of dysynchrony. The 2 measures that have been most commonly, so you can see how the myocardium contracts. In this case, the phase histogram is very narrow. The contraction, as you can see, is very quick and robust, so there is no dysynchrony. The quantitative numbers are here, the phase standard deviation, which is 24 degrees, histogram bandwidth of 59 degrees, and normal limits for men and women have been reported using the Emory Cardiac Toolbox software. And these are the mean and the plus 2 standard deviations of phase standard deviation histogram bandwidth values from normal men and women. Okay. Now you have to be careful. The numbers, the cutoffs for normal limits for dysynchrony are software specific. Okay. Just like your EF assessment and volume assessment varies between various softwares, if you use a 4DM, if you use a QGS, if you use Toolbox, because that's how the ventricle is defined and delineated in these softwares is different, and it's not the same. So you have variations in volumes and functions. That's the same reason why you can have variations in your normal and abnormal cutoffs for dysynchrony. Okay, so if you are serially assessing dysynchrony, it is recommended that you use the same processing software, because there can be differences within the softwares that can make differences in your quantitative dysynchrony assessment. Okay. However, the saving grace is that it's not just the quantitative assessment of dysynchrony that's important, it's also the qualitative assessment of dysynchrony that's even more important. Phase analysis can be applied to ERNA. Actually, it was first developed and noticed in ERNA many years ago in the 1970s. Phase analysis or phase analysis has been a usual output in your ERNA studies. For many years, we just didn't know what to do with it because we had no clinical application of that data. We just didn't know what it was representing, and even if we did know what it was representing, we just didn't know what to do with that information. Okay, so the top example is that of a patient who has a normal EF. His LV is contracting in one phase, all in one phase. It's all nice and green and has a very narrow histogram, whereas the patient here has cardiomyopathy, has a defibrillator right here. You see that photopenic region in the right chest, and has numerous different colors in the left ventricle, suggesting that the phases are different in different parts of the ventricle, or the different parts of the walls of the ventricle are contracting at different time points and are not in sync like the first patient, and has a wider distribution of the phase values, suggesting more dysynchrony. Phase analysis is highly repeatable. This is true not only for SPECT but also for ERNA. The error is less than 1%, partly because it's a semi-automated technique. There is very little user involvement. The softwares, as you would process your SPECT images, would throw out the dysynchrony information as well. And this just stems from the reproducibility of radionuclide imaging in general, and not just the assessment of dysynchrony. Now, as I mentioned, dysynchrony is a count-based technique, right? So it's the poor spatial resolution that is overcome by the Fourier transformation, which uses the counts in a portion of the myocardium to determine when it thickens. What if you have an infarcted myocardium and you have very low counts, right? Is your dysynchrony inaccurate in those cases? Now, this was shown in a phantom study from the Emory group many years ago. And it essentially shows that as long as you have a 5-pixel region with each pixel having at least 10 counts, and as long as you have 8-bin gating, 32-16 8-bin gating, you have enough fidelity to differentiate a normally thickening myocardium, which they defined as 40% thickening, from a less thickening myocardium, from severely reduced thickening myocardium, and from a myocardium that does not thicken at all. So in usual clinical practice, these are the kind of patients we would see who have infarcts, considerable reduction in the count density, but as long as they have at least 10 counts in a pixel on an 8-bin gating, you can separate the normal, the abnormal, the very abnormal, and the akinetic regions from each other. Okay, so yes, it still works even if you have very low counts. And why is that? This is a patient who has an inferior infralateral myocardial infarction. This is how the gating looks like. You know that the inferior wall, infralateral wall is severely hypokinetic to akinetic. You know, how do you know if there is thickening there? Well, this is normalized data. Okay, if you saturate the data, those infralateral wall, that infralateral wall also has counts. You just don't see it because the way we visualize images are normalized to the hottest spot in the myocardium, right? So the top is the normalized data, which is what we usually look at. The softwares see the background activity in the inferior wall, which is the raw data. So there are counts there. It's not that they're devoid of counts. It's just very low counts that are normalized so that we can appreciate the differences between normal and abnormal segments. But from a standpoint of assessment of dysynchrony, there are counts in the inferior wall. They're just less dense as compared to the other segments. Now, one of the biggest disadvantage of assessment of dysynchrony, and this would be true for any modality, would be gating errors. Dysynchrony is based on assessing the timing of contraction. So if you have gating errors, your timing of contraction is off. And if you read the nuclear literature, you would know, because you average counts over multiple cardiac cycles, your EF assessment, even in the presence of gating errors, is fairly robust. What is off is the timing of contraction, right? So this was studied in a simulation study from the University of Pittsburgh, where they showed that if you had severe artifacts, gating artifacts, there was a considerable reduction in dysynchrony as defined by the phase standard deviation, right? So patients who had less severe artifacts, the frequency of reduction in or abnormal reduction in dysynchrony values was much less as opposed to having significant gating artifacts. This is an example from that study. This is a patient who has dysynchrony at baseline. Okay, on the top panel, you see the phase standard deviation is 62 degrees. The histogram is fairly wide. The authors induced the gating error by pacing that patient so that the dysynchrony, so that the contractility was haywire, and the dysynchrony appeared to be, the myocardium seemed to be contracting synchronously. So gating errors result in artifactual reduction in dysynchrony or improvement in synchrony, even though there is dysynchrony, but gating errors can artificially produce dysynchrony. And if you correct that dysynchrony with the software approach that they use using MATLAB, then you can essentially match the true pattern of dysynchrony as shown there. This is an example from our lab. This is on the top is how you would assess the presence of gating artifacts. All your count data from 8 bins is lining up on the top panel. In the bottom panel, you see that there are 2 gates that are off. There is significant gating artifacts. So this would be gate 7 and 8 on an 8-bin gating, and gates from 12 to 16 in a 16-bin gating. So there's considerable gating error. This is an example of a patient with a reduced ejection fraction of 29%. And you can visually see that the EF is really low, right? So you would expect this patient to have dysynchrony, right? The EF is low, the walls are not contracting well. But assessment of dysynchrony actually shows that the histogram is fairly narrow, and the values, the quantitative values of dysynchrony are within normal limits. So this is how profound an effect gating errors can have on assessing dysynchrony. If you have list mode gating, which I know you all have with CZT, you have the option now and the advantage of correcting for gating errors and getting excellent results with dysynchrony, for dysynchrony with even in patients who have artifacts and gating errors and arrhythmias, although you would be losing considerable number of counts if you took the gating errors out. So what is the implication of dysynchrony in patient care? These are two examples of patients who, on the left is a patient who does not have dysynchrony, and on the right patient who has dysynchrony. You can see how different and how fast the timing of contraction is in this ventricle as opposed to the sluggish timing of contraction in this ventricle. And you can see the timing of latest contraction in this case is somewhere in this infralateral, midlateral wall. So it gives you a qualitative assessment of dysynchrony right there, in addition to quantitative assessment of dysynchrony. The second aspect of dysynchrony, the first aspect which I was talking about was a technical limitation, right? We were looking in echo only in 2 dimensions. Radionuclide imaging provides us an assessment in 3 dimensions, right? It is not directional, right? It is looking at counts from each voxel, and it doesn't matter how the voxel is contracting as long as there is change in the count density, whereas echo is directional, either longitudinal or radial, right? So you're losing the 3-dimensional aspect in echo. Now, is there a limitation in our knowledge? Now, this is where I'm going to talk about a little about echo in a few slides, because it's essential to understanding what we are missing in terms of how dysynchrony needs to be applied. This is the data from which the PROSPECT trial that I mentioned in the beginning that had really poor reproducibility was derived. This is an M-mode echo, motion mode, highest temporal resolution, about 2000 frames per cardiac cycle, right? As opposed to a 32-frame MUGA, this is 2000 frames. So highest temporal resolution. They define dysynchrony to be present if there is delay between the septum and the lateral wall, okay? However, if you see, this is a patient who has a left bundle branch block. This A point A, which is a blip in the septum, actually signifies an abnormal activation in a patient who has a left bundle branch block. That's just how their septum looks. And after that, the septum is fairly flat. Okay? This is where the myocardial contraction actually happens, and that point A is only a reflection of that electrical activation and does not contribute to contractility. Right? So we use this difference in contraction between point A and point B, which is now we know incorrect in assessment of dysynchrony. The example on the right is from our lab, and it shows that there could be 2 ways in which the myocardium can contract and be dysynchronous. This is in this case the walls are coming in. In this case, one wall is coming in and the other wall is not moving at all. Okay, so even though you can have heart failure and low ejection fraction, your walls could still oppose each other and have less or no dysynchrony, whereas in other case you can have significant dysynchrony. These are examples from 2 different patients. The white arrow here is showing the abnormal activation, electrical activation of the myocardium with this septal beak, and the red shows what the myocardium does after the contraction starts. And in the first case, the myocardium goes, the septum goes away from the posterior wall. So there is dysynchrony, contraction of the myocardium is not synchronous and is not effective, as opposed to case B, which also has a left bundle defined by this beak, by the white arrow, but after in systole, the myocardiums actually oppose each other. The septum and the posterior wall are coming inside. So all left bundle branch blocks don't behave the same way. Okay? Some could be dysynchronous mechanically, some could result in mechanical dysynchrony, some may not result in mechanical dysynchrony. Okay? This is an example of a patient who had a CRT. He had left bundle branch block at baseline with desynchronous contraction. There was the septum was going away, moving away from the posterior wall in systole. This patient received a biventricular pacemaker which corrected the contraction. Even the patient still has a left bundle electrical activation pattern, but the mechanical activation has improved, and now both the walls are contracting in sync with the improvement in LV contractility. Look at how wide the left ventricle was. This is the left ventricular cavity, and look how narrow and small the left ventricle has become now. Okay, so it has resulted in reverse remodeling. Your LV size has shrunk. The LV contractility has improved. Next is there a biological limitation? Okay, so in the patients in whom we are looking for dysynchrony, all these patients have heart failure and low ejection fractions. Now we know that if you have a risk factor that is highly prevalent in a population, the risk factor being dysynchrony, then the predictive value, the value of that risk factor to predict an outcome is going to be very, very low because everybody has it. Right? So it's not just the presence or absence, but how it behaves. Right? This is data from Echo and SPECT, patients with a narrow QRS complex and wide QRS complex with EF less than 50%. Dysynchrony is prevalent in about 50 to 73% of the patients. And our data from SPECT show that if you have an even lower EF of less than 35%, those are the patients who actually qualify for a CRT. Dysynchrony could be prevalent in as high as 90%. So if 90% of your patients have the risk factor, how will you be able to, on a biological basis, differentiate patients who would not improve if that risk factor was not present, when majority of your patients had the risk factor? In this case, it's dysynchrony. So yes, dysynchrony is important, but its simple presence or absence, although important, but it's not the whole answer. It's not the complete answer. And as I showed you from the echo data, it's actually how the ventricle reacts when there is dysynchrony. Even if there's a left bundle branch block, do the walls beat in sync, or are they desynchronous? So the pattern of dysynchrony is also equally important, if not more important. So the one thing is, maybe we should identify patients who don't have dysynchrony, right? Find those 10 to 15% of the patients who have heart failure and low ejection fraction, who don't have dysynchrony and who would not improve. And in the other 90%, identify the patterns of dysynchrony that can help you improve your outcomes with CRT. So left bundle branch block is insufficient alone to produce dysynchrony. This is my data from our lab. Patients with and without left bundle branch block, the only predictor of dysynchrony in this population with low ejection fraction was some rest score, or the infarct size and ejection fraction, and maybe the volumes. Left bundle branch block and QRS duration, electrical dysynchrony was not a predictor of mechanical dysynchrony. Similar data is shown from echo studies from before. This is an example of a case of a patient who has a left bundle branch block on EKG, severely reduced ejection fraction, wide QRS, a wide phase histogram showing dysynchrony, and a very sluggish contraction pattern with the site of latest contraction in the lateral wall, which is typical of left bundle branch block. In left bundle branch block, the septum is the first to contract, the lateral wall is the last to contract, and that's what we are seeing in the polar map. The septum contracts first right now, the contraction then spreads to the whole ventricle and ends in the lateral wall. This is an example, typical example of a patient who has heart failure, low ejection fraction, left bundle branch block, and has dysynchrony. You give a CRT to this patient and he will improve. Okay. On the contrary, this is a patient who has left bundle branch block, has a low EF. You can visually see that EF is low, has a very narrow phase histogram, and has no dysynchrony even on the polar map. As you can see, the contraction is fairly fast. Yes, the site of latest activation is still in the lateral wall because this is a left bundle branch block, but the patient does not have dysynchrony despite having a low ejection fraction, or mechanical dysynchrony despite having low ejection fraction and a left bundle branch block. Okay, so every left bundle branch block doesn't qualify as a mechanical dysynchrony pattern. So there is a disconnect between electrical dysynchrony and mechanical dysynchrony, and we've been able to show that with radionuclide imaging. This is a data that we presented at ASNC many years ago, showing that again, everybody that has a left bundle branch block, the site of latest activation is always in the lateral wall. Okay, as I just said, in patients of a left bundle branch block, the earliest contraction is in the septum, the last contraction is in the lateral wall. So no surprises, everybody with the left bundle has a site of latest activation in the lateral wall. Patients without a left bundle branch block, even in them 50% or 54% of the patients had the site of latest activation in the lateral wall. So you can assume that these patients without a left bundle branch block will behave the same way as patients who had a left bundle branch block. Okay? And maybe in them the benefit with this from a CRT would be the same as those who have a left bundle branch block. However, these patients would not have the same benefit from CRT unless you can guide placement of the CRT. Okay? So this is an example of a left bundle branch block patient, dysynchrony, site of latest activation in the infralateral wall. This is an example of patient without left bundle branch block, still dysynchrony, but the site of latest activation in the septum. Okay? So if you gave this patient CRT, this patient is actually not going to improve. It's very likely this patient is going to get worse. So what are the clinical implications of knowing the site of latest activation, which I call as a SOLA, S-O-L-A for site of latest activation. So this is an example cartoon of the conduction system of the heart. Okay, you have a right bundle, you have a left bundle. When everything is normal, they both activate at the same time with synchronous contraction of the ventricles. When there is a left bundle branch block, the left ventricle activates through the right ventricle. Okay, and when you put a CRT lead in the lateral wall of the left ventricle, you're trying to improve this timing of contractility and synchronizing the contraction between the septum and the lateral wall. This is how CRT is typically placed, with one lead of the LV lead going in somewhere in the lateral wall. Okay, so LV lead is often empirically positioned in the lateral wall. Okay, so you can imagine if patient has a left bundle branch block, every time the LV lead is in the lateral wall, of course they're going to improve, because the way CRT is implanted is effectively only targeting a left bundle branch block pattern. Okay, so if you have a septal to lateral wall delay that you can correct with biventricular pacing, you can improve resynchronization. What if you don't have a septal to lateral wall delay, as we saw in those patients who did not have a left bundle branch block, in which the site of latest activation could be in the anterior wall, could be in the inferior wall, right? So patients without left bundle branch block, but site of latest activation in the lateral wall may respond as well as those who have a left bundle branch block. However, patients without left bundle branch block and without the site of latest activation in the lateral wall will not respond to CRT unless you can guide the placement of the left ventricular lead. All right, so how can we inform the guiding of a left ventricular lead? How can we do that? Now, this was a study of 44 patients from the University of Pittsburgh, in whom assessment of dysynchrony was performed before and immediately after activation of the biventricular pacemaker. So what did the authors do? They injected a single injection of high dose technetium 99M. They acquired resting images, and these are the patients who already had a biventricular device implanted the day before, but the left ventricular lead was kept inactive. The patients had a first resting technetium scan done, followed by activation of the left ventricular lead. So now they are being paced from both sides of the ventricle with repeat acquisition, gated acquisition. So you had two sets of acquisitions from a single injection of technetium, okay, within an hour of each other. And this is an example that shows pre-CRT, this patient has dysynchrony, there's dysynchronous activation of the ventricle. Post-CRT, there's two sites of activation. This is the RV lead in the apex, and this is the left ventricular lead in the lateral wall. And there is considerable improvement in dysynchrony with narrowing of the phase histogram. Okay? So in these 44 patients, pre-identified predictors were baseline dysynchrony, so presence of dysynchrony, presence of a burden of the scar. If the scar burden was less than 40%, prior observation studies have shown that if you have a higher scar burden, more than 40%, then CRTs don't work, because there's so much scar, there's so little viable tissue that even by biventricular pacing, there isn't enough myocardium that you can recruit for effective resynchronization. So baseline dysynchrony was one preemptive predictor, scar burden was a second preemptive predictor, and the third predictor was lead concordance with the site of latest activation. Is the left ventricular lead positioned at or close to the site of latest activation, as we just saw on SPECT, right? We saw the pattern of contraction, you can identify where the site of latest activation is. And the authors found that if you met all the three criteria, you had a positive predictive value of 96% to predict improvement or no change after CRT, okay, when compared to worsening after CRT. So if you had baseline dysynchrony, which we've all talked about, that dysynchrony is important for CRT. Second, you have a scar, myocardial scar, which occupies less than 40% of the left ventricular myocardium. So there is a lot of viable myocardium that can help improve contraction. Third, you have a left ventricular lead which is in the site of latest activation. Now this included patients who had and who did not have a left bundle branch block. Then you can predict improvement with CRT with a 96% positive predictive value. So in their study, they also found that acute change in dysynchrony predicted outcomes. If there was deterioration in dysynchrony soon after activation of the biventricular pacemaker, there was an increased number of death, heart failure, hospitalization, appropriate defibrillator therapy, and even deactivation of the biventricular pacemaker, because the patients were doing worse after the biventricular pacemaker. Now, how can we assess or how can we use dysynchrony to guide optimal positioning of the left ventricular lead? This was shown in the starter trial. This is an echo-based study of 187 patients who were randomized to echo-guided placement of the left ventricular lead, whereas empirical placement of left ventricular lead based on the operator's recommendation of where they could implant the LV lead. The endpoint was heart failure, hospitalization, or death. And this is how, using speckle tracking echocardiography, they identified the site of latest activation. This is the basal left ventricular wall seen as a donut. This is the mid left ventricular wall seen as a donut. And as you can see, the white arrow on the top right points towards the basal infralateral wall, which is the last to contract. So that was a site of latest activation on echo. And they found that echo-guided lead positioning provided better outcomes. Patients did better in the echo-guided lead implantation arm as opposed to routine lead implantation arm, which is often in the lateral wall. That's where the operators implant the left ventricular lead. This can be done with SPECT. Now, SPECT has the advantage that in one image, one acquisition, you get data on perfusion. With that, you get data on function, you get data on where the scar is. You can quantify your scar based on the sum difference score and the percentage of the myocardium that's scarred, and also get the phase information. And not only that, you can get information on the site of latest activation and whether the site of latest activation is in a scar. Because if the site of latest activation is in a scar, implanting LV lead in scar is not going to help, because there's going to be no electrical activation. So you need to find another optimal site to implant a lead. This is data from the MRI group showing a single injection of technetium providing data on perfusion. Okay, so you can see the perfusion in the anterior wall is preserved. Data on phase, which is the timing of contractions. In this case, the basal anterior wall was the last to contract, which is also viable and doesn't have scar, and also provides you a guidance map. So 1, 2, and 3 here refer to the segments of the left ventricle that the software says are appropriate for lead implantation in that order. So 1 would be the basal, the mid anterior wall, 2 would be the mid anterolateral wall, and 3 would be the basal anterior wall. With that information, you can tell your electrophysiology colleagues that, hey, look for a coronary sinus branch that goes towards the basal anterior wall or the mid anterior wall, and try to implant your LV lead in that segment. And in this patient, that's how this was done, resulting in improvement in patient symptoms and reduction in the QRS width. This is an example of regional dysynchrony guided CRT from our lab. This patient has a left bundle branch block, wide phase histogram showing dyssynchrony. This is the polar perfusion map and the contraction sequence showing that the site of latest activation is in the infralateral wall, and implantation of an LV lead guided by this information resulted in significant improvement in narrowing, actually normalization of the left end of the QRS. Now this was a patient who had a left bundle branch block, so it is not surprising that he improved to such an extent. Okay? Compare that to this patient who does not have a left bundle branch block, does not have a classic left bundle branch block, has a wide QRS, has a site of latest activation actually in this anterolateral region. Okay? And this is a coronary sinus venogram. This is what the electrophysiologists do when they are implanting a biventricular left ventricular lead. This is the coronary sinus, and these are the branches of the coronary sinus here. These are the branches in which the left ventricular lead is implanted. Now you can see a site of latest activation is in the anterolateral wall, which is that bright spot on the top, but there is no branch of the coronary sinus in the anterolateral region. So the operator had no choice but to implant it in the infralateral region. That's the best they could do, although there was some reduction in the QRS width, but it was not normal. It was still 130 milliseconds. Okay? So it's not just the presence of dyssynchrony, it's not just how the ventricle contracts, but the underlying substrate, whether the myocardium is viable. And even if everything works, but you don't have a coronary sinus anatomy that is congenial to dyssynchrony guided lead implantation, your CRT will not benefit to the extent that we expect it to benefit. Okay. So what is, in my opinion, the application of dyssynchrony for CRT in the future? So again, symptomatic patient with heart failure, ejection fraction less than 35% and a wide QRS. By current guidelines, these patients get a CRT, no questions asked. Okay. But we've just seen that application of CRT is much more complex, especially now from the dyssynchrony information that we're gathering from radionuclide imaging. We know that if you're not desynchronous, despite having all these features, you will not improve with CRT. Okay? If you have dyssynchrony, but you have a lot of myocardial scar, implantation of a biventricular pacemaker will not improve the contractility to a great extent, and you may not benefit from CRT. So those patients should not qualify or would not qualify for a CRT. If you have myocardial scar, but that's less than 40%, but the site of latest activation is at the myocardial scar, either don't implant the CRT or find another site. Okay, find another appropriate site which is outside of the scar. You find an appropriate site, but your coronary sinus venous anatomy is not ideal, right? Like we saw in the last patient. Even if you implanted a device, the benefit would be less. If you meet all these criteria, then you should get the CRT, and this is how the effectiveness of CRT can be improved. Now, we talked about efficacy versus effectiveness in the previous talk. The efficacy has been shown in randomized controlled trials versus controls, right? But we know that less than 50% improve. So this kind of a paradigm, this kind of an approach, this data from a mix of observational and small randomized controlled trials shows that you not only have to use the low ejection fraction and electrical abnormalities, but also the presence of dyssynchrony, the presence and extent of myocardial scar, assessment of regional dyssynchrony or the site of latest activation, and whether you have an ideal coronary sinus anatomy, and only then you can improve the effectiveness of CRT. Okay, so dyssynchrony, as we have just seen, may sound like it's only applicable to resynchronization, right? That just makes more sense. But there is no new and upcoming information as to the value of assessment of dyssynchrony beyond resynchronization therapy. So we know that ejection fraction has a limited ability to predict ventricular tachyarrhythmia, right? Patients with low EFs, less than 35%, receive an ICD. And I know you may be doing a lot of MAGAs to identify their EFs. And the reason being, if they have EF less than 35%, they get ICD for primary prevention of sudden cardiac death. And ICDs have been shown to improve mortality in patients with low EF. And selection of patients for ICD is based on EF alone, based on these multiple randomized controlled trials, although ejection fraction by itself has nothing to do with arrhythmogenesis. Okay? It is just a feature of a bad myocardium which cannot contract well, and because of the same reason it has poor predictive value. This is data from the Danish registry that shows that in patients who have an ICD or a defibrillator of some sort, 30% or more than only 30% of the patients ever receive any therapy. So more than 2/3 of the patients don't receive any life-saving therapy. And actually, and the electrophysiologists will also tell you that among patients who receive a therapy, only 10% of that is life-saving, because most of the arrhythmias are actually slow and not fast enough to be life-threatening. So we need to better identify patients with low ejection fraction who would benefit from an ICD implant. That's one way of doing it. Or to identify patients with low EF who will not benefit from an ICD implant. Okay? And I've been highlighting this. This is true for CRT too. This is a more clear group to identify than these people. Okay? Ones who are not going to improve is easier to identify than those who may or may not improve. Okay. So what are the potential predictors of VT? We know about EF, it's poor, but EP markers are there, heart rate variability, T-wave alternance. I'm not going to go into details of that. What's pertinent to you all is MIBG, or neurohormonal denervation of the left ventricular myocardium has been shown to predict VT if the HM ratio is less than 1.6 in the ADMIRE-HF study. Hopefully we'll get more data from the ADMIRE-ICD study that both yours and my health centers are sites of. However, there are no clinical applications. We don't actively use MIBG for cardiac denervation because it really does not inform decision making. Yes, it may give you information on prognosis, but we need something more than just bad prognosis to guide management. Recent studies had in 2010 we started doing this phase analysis, had started at the same time, and there was emerging data that abnormal indices of phase analysis were associated with VT. This is data from the University of Alabama, Amy Skundrian's lab, showing if you had a high standard deviation and actually patients who had events had a greater degree of dysynchrony defined by phase standard deviation and phase histogram bandwidth. This was a mix of patients with EF less than 40% and not our typical less than 35% patient population. So we took this to the next level. We did a retrospective study of 183 patients, all of whom had an ICD and had a gated SPECT performed before their ICD. Okay. We went back and analyzed the gated SPECT data for the presence of dysynchrony, which is another beauty of gated SPECT, that if you have your data, you can always post-process it even after the fact to get the dysynchrony information, and it doesn't have to be done right there and then, which is not true for many echo techniques. Okay. We found that patients who had no dysynchrony had nearly no events over a period of 5.5 years, except for one patient who had an arrhythmic event. Now, arrhythmic events were defined by ICD discharge, anti-tachycardia pacing, sudden cardiac death that was not aborted by the ICD. So we were very inclusive in terms of what we defined as arrhythmic events, as opposed to patients who had dysynchrony in whom majority of the events occurred. So almost nobody without dysynchrony experienced an arrhythmic event, even though all of them had low ejection fractions and met the clinical criteria for an ICD implant. This was true for both sustained and non-sustained VT. The non-sustained VT are not life-threatening VTs, but the occurrence of non-sustained ventricular arrhythmias were also less in patients who did not have dysynchrony. Now, this was using hard cutoffs based on the Emory toolbox that I just showed you. Okay, so the presence and absence of dysynchrony was very specifically defined by the quantitative assessment of dysynchrony by Emory cardiac toolbox. The only predictor of arrhythmias in this patient population was dysynchrony. So if you look at the right panel, which is the multivariable predictors of arrhythmias, None of the other variables, scar burden, ejection fraction, QRS duration, left bundle, were predictors of arrhythmias. Only dyssynchrony was the predictor of arrhythmia, ventricular arrhythmia in these patients. So in our study, we found that dyssynchrony had an excellent negative predictive value for VT. Patients who did not have dyssynchrony did not have VT. There was only one per patient, so 98% negative predictive value. If you did not have dyssynchrony, you would not have VTs. Okay. Now, what about patients who had dyssynchrony? Right? These are the patients who had dyssynchrony. Can we identify? So this tells us the group of patients who had the lowest risk of having arrhythmias. Patients who have a low ejection fraction but no dyssynchrony are at the lowest risk of having arrhythmias. Okay. Can we identify patients who are at the other spectrum, who are at the highest risk of having arrhythmias? Right? So among patients who had dyssynchrony, we found that a scar burden of more than 6% or more than equal to 5, some difference score of 5, identified 92% of the patients who would have arrhythmias, ventricular arrhythmias. So a combination of absence of dyssynchrony would identify patients who are not going to have arrhythmias, and a combination of dyssynchrony and greater than 6% left ventricular scar identifies the other 92% of the patients who would have arrhythmias. Okay, so you can segregate patients who are at the lowest spectrum of having arrhythmias and patients who are at the highest spectrum of having arrhythmias. So ones who should definitely get an ICD and ones who should definitely not get an ICD. Okay. They would, from an ICD, would, so the 40% would lie somewhere in this range. So patients who have dyssynchrony and 40% scar, the reason they are dysynchronous is because they have 40% scar, right? The reason their EF is low is because they have a 40% scar. So they are very likely to have arrhythmias. But patients who have dyssynchrony but have low scar burden, less than 6% myocardium, are less likely to have arrhythmias than patients who have larger scar burdens. Okay. Now, this is a combination of CRT and VT. Okay, so now in our population, we had 43 patients who, as I showed, who underwent CRT, underwent dyssynchrony assessment both before and after CRT implantation. Okay, so those patients had both a CRT and a defibrillator. We assessed CRT before, dyssynchrony before and dyssynchrony after CRT, and we divided them into 4 groups. Group 1, very few patients who had no dyssynchrony to begin with and had no dyssynchrony after CRT. Okay. Group 2, who had dyssynchrony before CRT and in whom dyssynchrony completely resolved with CRT, normalized. Group 3, who did not have dyssynchrony before CRT, but CRT induced dyssynchrony in them, right? So these are the patients who received a CRT even though they did not have mechanical dyssynchrony. And group 4, majority of the patients who remain dysynchronous, right? The dyssynchrony may have improved, but they still remain dysynchronous. We noticed that, of course, patients who had no dyssynchrony had no VT, right? Patients who had dyssynchrony, but in whom dyssynchrony went away with resynchronization therapy, had no VT. So resynchronization, complete resynchronization, was protective against VT. Patients who were dysynchronous had VT. Of course, we know this was about 28% of the population. Very importantly, in patients in whom we induced dyssynchrony with CRT, had the same prevalence of VT as patients who had dyssynchrony before. So this is a group that did not have dyssynchrony to begin with. We made them dysynchronous and they had arrhythmias. Compared to patients who had dyssynchrony to begin with, we took their dyssynchrony away with CRT, had no arrhythmias. Okay, so very profound data, small but very profound data suggesting that the effect of the anti-arrhythmogenic effects of CRT is probably from reduction of dyssynchrony. Okay, and it can be pro-arrhythmic as well. If you induce dyssynchrony with CRT, it can be pro-arrhythmic too. This is an example of a patient in whom the dyssynchrony completely went away, had no VTs, example of patient in whom dyssynchrony was induced and had VT after CRT. So we concluded that dysynchrony is a product of diseased myocardial substrate. Now that could involve electrical abnormalities, that can involve LV dilatation or how dilated your ventricle is, that can involve scar burden, and we think that there is a combination of this abnormal myocardial substrate that makes the ventricle arrhythmogenic. Okay? And this combination of the myocardial substrate likely manifests itself as mechanical dysynchrony that we can image with radionuclide imaging. Okay? So, moving on to the third aspect of dysynchrony, okay, there's more than meets the eye to dysynchrony. So we talked about CRT, which was the most obvious thing. Then we talked about arrhythmogenesis, which is, yeah, okay, that's new, that's, you know, what else can dysynchrony do? And tell us about it. There's emerging data that dysynchrony can help predict inducible ischemia. There is less data on ischemia in relation to dysynchrony than there is to CRT and VT, but this is thought-provoking. Patients who had normal perfusion with stress, there was an improvement in the phase standard deviation. Patients in the infarct group had worse dysynchrony, of course we know that. Patients in the ischemia group, okay, had more dysynchrony on stress as opposed to rest, right? So in the first group, patients who were synchronous to begin with, there was a slight improvement in synchrony with stress. Patients who had ischemia had worsening synchrony with stress, okay? A further study from the same group showed that incremental value of dysynchrony in predicting multi-vessel disease. If you look at perfusion alone, perfusion with change in ejection fraction, perfusion wall motion, dysynchrony alone, perfusion and dysynchrony, addition of dysynchrony to perfusion identified a greater percentage of patients who had multi-vessel disease than perfusion alone. Okay? So if your left ventricular contractility fell, worsened after stress, that was an indicator of multi-vessel disease. Okay, not just ischemia, but multi-vessel ischemia. This is true for PET as well. This is data from PET. This is from one of the editorials that I wrote on relationship between dysynchrony and myocardial blood flow. Okay, this was rubidium PET data showing that patients in whom there was improvement in post-left ventricular dysynchrony, post-ventricular synchrony, had excellent myocardial blood flow at rest and stress. Okay. Patients who had severe infarctions, okay, these have large infarcts, left ventricular remodeling, had really no improvement in dysynchrony, and they continue to remain dysynchronous with stress. Now, the premise was that when you do vasodilator stress, there can be improvement in ejection fraction because of recruitment of myofibers. Okay, the vasodilation results in recruitment of myofibers, something which we refer to as Gregg phenomena. The recruitment of myofibers results in improvement in LV function, and the PET people will actually say that if the EF does not improve on stress imaging, that signifies ischemia, even though your perfusion might look normal or might signify microvessel disease. Okay? There is a group of patients who have microvessel disease in whom there is resolution of dysynchrony with stress. So there could be a component of what we call a synchrony reserve, that your myocardium is dysynchronous at rest because of microvessel disease or something similar, but when you vasodilate these patients, when you treat the microvessel disease, maybe there is improvement in synchrony in some patients, and that could be referred to as synchrony reserve, and that may be the reason why some of the EFs actually improve with stress, vasodilator stress. And in a proportion of patients, there could be only dysynchrony at stress, resting perfusion is normal, resting synchrony is normal. However, there's only stress-induced dysynchrony, and so that relates with proportionally less improvement in myocardial blood flow as opposed to the other patients. And cardiac synchrony improves after revascularization. This is our data from University of Pittsburgh when I was a fellow there. We looked at a group of patients who had SPECT done before and after revascularization, whether it's coronary artery bypass grafting or whether it's placement of coronary stents. And we noted that in these patients who had a SPECT after revascularization, there was a significant, statistically significant improvement in desynchrony. If you look at the numbers, the mean values of synchrony are actually still within the normal range. All right, there is further improvement in synchrony. What that means from a clinical standpoint, we don't really know. Okay, but we at least know that ischemia is associated with desynchrony, and improvement or reduction of ischemia with revascularization or medical therapy results in improvement in cardiac synchronization. And we further noticed that patients who had more than 10% ischemic myocardium versus less than 10% ischemic myocardium had a greater reduction in synchrony after revascularization. So if you had more ischemia to begin with as compared to less ischemia to begin with, there was a greater reduction in desynchrony or greater improvement in synchrony after revascularization. So phase analysis or assessment of desynchrony by phase analysis of radionuclide imaging is reproducible. It's a reproducible technique to determine contractility. It provides information on global desynchrony and regional desynchrony. The advantage is, of course, it's widely available. It provides information on standard perfusion. You don't have to do a fancy protocol. This is a standard perfusion protocol. It gives you comprehensive information on function, perfusion, scar, global desynchrony, site of latest activation, okay, whether the site of latest activation is in the scar, so global and regional desynchrony, and it's advancing our understanding of the mechanistic basis of CRT and arrhythmogenesis, and may help us in prediction of ischemia as well. Thank you.